Hi everyone, I'm Jay Sibolyeha. My presentation for our class is about geriatric depression. Geriatric depression is pretty much depression among our elderly community. It affects me personally and of course all of us eventually because it's the largest growing population in our community. More on that later. So what is geriatric depression and how does it affect the elderly? Well, aging is a universal process to be observed in all living things and causing regression in all functions. The individuals may experience various problems in biological, psychological, and social dimensions together with the aging. Statistics show that more than 2 million of the 34 million Americans aged 65 and older suffer from some form of depression. Study shows that it's the most prevalent mental illness worldwide. The expectation for 2020 will be the second global cause of inability, and it's the fourth largest incapacitating agent. It's an agent that produces temporary physiological or mental effects or both, which will render individuals incapable of concentrated effort in the performance of their assigned duties. The topics I'm going to be discussing are from the data for the depressive symptomology of the distribution, the symptoms, the self-efficacy levels, the roles of life space, screening scale, and psychotherapy and pharmacotherapy. So for the data from the research paper that I found, there were 861 elderly participants in the study. 378 or 45% is without depression and 454 or 55% is with depression. The highest proportion of elderly people affected by disease indicated were those aged from 75 to 85 years old, or 56.4%. Depression tends to increase with age progression, and the highest peak lies between 70 and 79 years old. As for the variable marital status, the results found was higher number of widowed individuals with depressive symptomology, 46%, corroborating other studies which point out the loneliness or mounting due to death of a spouse in old age may be a risk factor for developing depressive symptoms. Okay, so for the data that we found, 70% of females are more depressed than males, as you can see. The place of residence also makes a big difference. So geriatric homes or care homes are 46% compared to 28% for the community homes, which are the elderly that live in their own home. The 26% is daycare centers, so it's a combination of both home and a program outside of the community. Again, for the marital status, it's actually the married couples are less depressed other than divorce, which makes a lot of sense. Also, the widowed is like the most in the community that are depressed. Age group also matters, as I said earlier, that the older you are, the more depressed that you get. I think it's because of how they deal with mortality. They think they're about to die, and of course that's kind of depressing to think about. So these are the symptoms and common causes of depression in elder people. You can see there like feeling guilty, self-depreciation, hopelessness, and having insomnia and anorexia or weight loss. So the causes are usually non-existence of family support, economic poverty, sickness, or depending on others. So again, like I said in the graph earlier, which I can go back to, it's because the family is not around, like when they are in the geriatric homes, they get more depressed actually. So self-efficacy levels and depression in individuals over 65 years old. The physical and psychosocial limitations, chronic illnesses, increased independency to others affect the self-efficacy and autonomy of the individuals negatively and form a ground for suicidal thought and depression. So the highest suicide rates were noted among older men. Again, you see here, so the chronic illnesses, social limitations, increased dependency on others will have negative effect, and then it leads to suicidal thought and depression. So self-efficacy includes the self-confidence of individuals and their success to cope with difficult situations. So individuals with higher self-efficacy can cope with crucial matters in an easier way, and they experience less depression. Okay. Nurses working in the field of mental health require to know about self-efficacy, depression, and the other factors with those concepts for the care of elder people, and to plan the nursing attempts to increase the independency of older individuals during their care. But With lower efficacy, of course, they have all the symptoms of depression, the self-confidence and stuff, and increased anxiety. But for the ones with higher self-efficacy or higher level of functioning, pretty much, they can understand things better and they work harder to achieve their goal, depending on what age group they are, really. But it's just the way how they deal with achieving their goal. So here are some preventive care and considerations. In all these implementations, especially the mental health nurses working in preventive service have great responsibilities that is suggested that the nurses to be aware of their respective responsibilities on the matter. So they want to define depression at earlier stage. They want to make the implementation and programs to be more self-efficient. It shows it has also psychiatric rehabilitation services, and then of course again family support is very, very important for elderly people. So the next topic is about role of life space, social activity, and depression on the subjective memory complaints. So subjective memory complaints is a type of everyday concern cited by people among middle-aged group, especially by the elderly. There are previous studies that identified different factors affecting subjective memory complaints. So life space is a multi-dimensional construct that integrates physical performance with motivational, psychological, and social factors that influence how one navigates and interacts with the real world. Social activity is a part of an engaged lifestyle that may help mitigate the deleterious effects of advanced age on cognitive functioning. And depression, of course, is the medical illness characterized by persistent sadness, discouragement, and loss of self-worth. So life space, social activity, and the presence of depressive symptoms are considered determinants of subject memory complaints. Only depression was found to have direct effect on subjective memory of the elderly. So moreover, depression is influenced by life space. Social activity and life space were found to have direct correlation with one another. Finally, social activity revealed to be determinant of subjective memory complaints. So again, in this topic, decreased life space and social activity leads to depression and leads to subjective memory complaints. So if you have increased life space and social activity, it's less depression and of course less complaints. So again, from the results of the study, the more social you are, the bigger the life space you have, are less likely that they will have depression. So depression among the elderly significantly contributes to a high level of subjective memory complaints. Healthcare providers should take into account that subjective memory complaints may be a presentation of depression or may coexist with other physiological and cognitive problems. This in turn helps such workers better evaluate the deterioration of memory or dementia among the elderly. So these are the implications for care from the study. Nurses and other members of the healthcare team should work together and tie up in providing holistic care to improve overall well-being of the elderly. Open spaces should be provided in the community for them to encourage socialization and widening the life space of the elderly. Nurses and healthcare providers should encourage verbalizations among the elderly to promote self-expression, and reinforcements of the protocols should be made by using assistive devices among the elderly. So assistive devices like canes and wheelchairs and even the bus or a handy van would help them a lot too, so they can congregate and have a social activity. So the next topic is about the screening scale for depression based on old age scale, which is the DIAS, and then the Geriatric Depression scale, the GDS-15. Both are administered orally, or it's a questionnaire. So it's a yes and no answer that the researcher or the person that's doing the study asked the elderly person or the subject. So it's self-rating, it's a fixed response, and then it must be suitable for verbal administration and must be easy to understand and to respond to. So these are the screening questions. Am I feeling down? I'm worried about the future. It's hard to motivate myself. From the DIAS, and then from the GDS-15, some of the questions are: do you feel happy most of the time? Do you often feel helpless? you prefer to stay at home rather than going out and new things. So all these things trying to factor into the fact that they're depressed or not. Again, as you can see, a lot of the questions are basically how their activity is during the day. The more they stay home pretty much is the more depressed that they get. So going back to life space and social activity is a huge factor on their lifestyle and on their depression. So the last topic is about psychotherapy and pharmacotherapy. So psychotherapy is what a psychologist do. It is pretty much therapy, which is talk therapy. It's about, you know, having sessions with a consumer or client, and pharmacotherapy is about medications. So a psychiatrist would provide pharmacotherapy. There's a good evidence to support that use of psychotherapy and pharmacotherapy alone and the two in combination works for the elderly. So for mild depression symptoms, it's recommended that psychotherapy is enough. It stands as alone, and then it's required. If required, then they can get meds too. For moderate, it's both pretty much. It's recommended, and if it's required. And then for severe, then that's when you go to meds. Okay. So for the therapy strategies, from the psychotherapy side, we have the CBT, or the cognitive behavioral therapy. So what is that? It's based on a theory that patients' interpretation of situations affects mood and behavior. So it's effective with waitlisted patients, were used as controls, but was not shown to be superior to other forms of treatment. PSD, or problem-solving therapy, it involves teaching the patient to identify problems, brainstorm solutions, implement a solution, and evaluates its effectiveness. So it appeared to be effective for those with depression and executive dysfunction. And IPT, or interpersonal therapy, is a structured time-limited treatment based on the premise that onset and recurrence of depression. And then for the side of pharmacotherapy, using antidepressants, medications, and the full remission of symptoms should be the goal of the treatment. So it is seen that factors should be considered would be for pharmacotherapy should be previous response to treatment, the type of depression, other medical problems, other medications being used, and the potential risk of overdose. Again, patients with severe LD should be referred to mental health services, possibly emergently, and started on medication immediately. So that's the end of my presentation. These are the references I used. I will actually include the PDF and the slideshow that I just did. Thank you for listening to my presentation. Let me go back to why I chose this subject personally. It is because I'm living with both my parents. One is 81 years old, my father, and my mom is 80. My mom is the one that I think she's not diagnosed, that she has depressive symptoms from like the selective memory and all the observance that I see. There's a part in the research also that I didn't talk about, or I didn't put in the slideshow, which includes the role of clergy in the community. Well, it's probably the first thing that I will use, or I will ask her to use for therapy for herself before going to someone that's professional, because she's closely tied with church. She's also a minister, by the way, including my father, but their relationship is different, so they cannot have therapy together. But I will ask my pastor to probably help in this case, because my mom has been showing signs of depression, like crying all the time, the memory loss, and I think it's because she's dealing with the fact that she's getting older, and she used to be so dynamic. Her life is so dynamic, she's so busy, and now she really cannot do those things, and her memory is like going away. But I will definitely speak to my pastor about this, about her, and they're pretty close, and hopefully it will help her in the end. And I will do my best to. I haven't gone through the GDS scale with her yet, with those personal questions, the yes and no questions, but I will do it, and then I'll keep you guys posted and see how it is. But anyways, thank you for listening to my presentation, and hopefully I can also see you guys' presentation in the future. Thank you.